Thanks very much for the kind introduction. Okay, yeah, so I'm going to be talking about auditing and nomograms, like playing with your data. Financial interests, as per Professor Reinstein previously. So we start with analyzing your outcomes. And the good news is with refractive surgery is we've been doing it long enough now that there's a very formalized, categorically sort of defined way of analyzing your outcomes. And it's summarized in the 9 standard graphs. So these are the 9 standard graphs. And we're going to run through each of these. And I'll just kind of point out, I'm sure you're familiar with them, but I'll point out a few key points on each one. So first of all, we're looking at efficacy, so uncorrected visual acuity. It's the obvious first thing you look at. Now, the most important point about this graph that often gets overlooked is that you should also report side by side with the uncorrected vision is the best corrected vision. So you're always reporting your outcomes in the context of your population. So a population of fighter pilots is obviously going to get better outcomes than a population of amblyopic eyes. So it's always important to be aware of the best corrected vision as well as the uncorrected. Not one of the 9 standard graphs, but it's also important, especially when you're looking at presbyopic patients, to report binocular as well as near vision and intermediate vision. But the problem that I just stated about efficacy is solved in the second graph, which is where the efficacy is normalized to the best corrected vision. So it's evaluated as the line's difference between the uncorrected post-op and the pre-op best corrected vision. So that normalizes all of the studies to what the patient really experiences. It's like, what was your vision post-op compared to your glasses? So that's what the patients could really understand. Safety is obviously extremely important. We measure this as Dan Gore was explaining earlier about the best corrected vision being not changing by the treatment, or in the case of an irregular case, you want to actually improve that best corrected vision. So the safety is a very important parameter for outcomes analysis. The attempted versus achieved is the refractive accuracy. I'm going to skip this one because I'm going to talk about it in more depth later in the talk. But the refractive predictability is how close were you to what you were aiming for. How close are you to your target, and were you under or over-corrected, displayed here as a histogram. Stability as well is very important to measure in terms of refractive surgery. We want to make sure that the change that we make to the cornea or the lens is stable over time. So you want to measure that refraction at different time points, and then you plot it on a graph to see, to show that it's stable. What we usually see is, like at the one-day appointment, you want to see a slight overcorrection on your treatments, because at that point you still have edema that hasn't subsided, and you know that biomechanical and epithelial responses are going to bring that back to target. So you expect to see that little spike at day 1. Cylinder analysis, this gets a little bit more complicated, which we won't have time for to go into today, where you need to do vector analysis because you've got the magnitude and the orientation of the cylinder. But that's an important thing to learn about, which you can measure here. This is the magnitude change. It's similar to attempted versus achieved for sphere, but for cylinder. And then the angle of error is an evaluation of whether you did your treatment on the right axis or not. So in terms of collecting your data, this is obviously, you can't analyze data if you haven't collected it. So this is a big hurdle, or some people see as a big hurdle, but it's a very critical stage in analyzing your outcomes, is to collect the data in the first place. And what I want to show is, don't be scared of collecting your data, because actually you don't need that much to be able to do the full 9 graphs. So all you need is the pre-op refractions and the target. You have the post-op uncorrected visual acuity, which gives you the first graph. You have your post-op refraction, just one time point, will give you all of the refractive outcomes. And then your best corrected vision before and after will give you the safety. And then if you want to go the full hog and go stability, then obviously you're going to see the patient at more time points as well. But what are the applications of now you've done your analysis, what are the applications? Well, obviously you can monitor your own outcomes, and if you're in a group, you can compare between each other. You can show those outcomes to your patients, submit abstracts to conferences, publish in journals. But one of the key critical things is that you can then use that data to improve your future treatments by deriving a nomogram. And so we're going to look just today at the spherical equivalent nomogram, which is based on the attempted versus achieved graph. So what is this? If we take it down to the most basic principle, what are we actually meaning by attempted? So with attempted, you have your pre-op refraction and a target, and then from that, you calculate the attempted correction that you're trying to do. So it's the pre-op minus the target is the attempted. Now, obviously, a lot of cases, you're aiming for 0, so the pre-op and the attempted are the same. But there are situations, for example, if you're doing a monovision case, where your target is non-zero, so you might have a minus 1.5 target, for example. So in that case, your attempted is minus 2.75 minus 1.5, so you're only attempting a minus 1.25 diopter change. So that's an important thing to remember when you're talking about attempted correction. But for a nomogram, you actually want to be looking at the numbers that you put into the laser. So you want to use the laser spherical equivalent when you're talking about a nomogram. So the achieved is almost exactly the same, but it's just now the difference between where you started the pre-op and where you ended up the post-op. So it's just one minus the other. At what time point do you want to do? You want to wait at least 3 months because you need the epithelium to remodel, the edema to subside, and the tear film to sort of get back to normal. So usually 3-month data is kind of what you're looking for. So now we're plotting these on a graph. So what we have the attempted correction in this case is a minus 2.5, and this is the attempted is the x-axis. So the minus 2.5 is on the x-axis, and in this example, the post-op was minus 0.5, so we've achieved less, so you've only achieved minus 2. And that's the y-axis. So when you plot that data point here, you can see that the blue data point is underneath the blue line, and the blue line is equality, so 1 to 1. What you're aiming for is what you get. So that's like sort of an undercorrection. Now obviously, if you're looking at a nomogram, this is just one eye, and you know there's biological variability, so you can't expect to have all eyes for all eyes to be undercorrected. So what you need is to do more treatments. And now, once you've done more treatments and you plot them on the graph, you can draw the average through that group, and you can see in this example, there's as many overcorrected as undercorrected, which means on average you're on target. Okay? Now it may be that when you plot the graph, all of your eyes, or most of your eyes, are undercorrected, at which point this is where you want to start using a nomogram because you want to improve your outcomes for the future. So this is the simplest form of nomogram where you've got a consistent, uniform undercorrection. So you can adjust all treatments by, say, 0.5 diopters, and then you shift that line up to where you want it to be. More likely is that you'll find that the higher corrections undercorrect more than the lower corrections. And so the next simplest option is to use a stepwise nomogram where you can use a different adjustment for higher amounts of myopia. And it's a very simple thing to do. You can just stick it on the side of your laser, and then you just make the adjustment accordingly before each treatment. And this is going to make a huge impact to your results. But take it one step further is you can actually use the data that you've collected from your attempted versus achieved graph, and you plot the linear regression line. And you can do this in Excel or any statistical program, and it'll display the equation for you. And so what you're aiming to do is you're aiming to shift this histogram distribution from the left-hand side to be centered in the middle, so that on average your procedures are on target. And so how do you do that then? So once you've got your regression line, then we need to do a little bit of high school maths. The equation of a straight line is y equals mx plus c, where m is the slope, the gradient of the line, and c is the intercept, or where it crosses the y-axis. So in this case, once you've got your equation, how do you actually use it to plan for future cases? So what we want is, now we're looking into the future. So if I've got a -6 treatment, then that's what I want to achieve. So that's now the achieved number. And if I take that from the y-axis until it hits the red line and go down to the x-axis, then where it hits the x-axis is what I need to put into the laser to achieve a -6. So I need to put in a -6.26 to get -6. And so if you do the maths, you've got to rearrange the equation, but you'll find that, once you've rearranged the equation, that's the formula that you want to put into your spreadsheet, and then you can use that moving forward for your future treatments. Some of the things to really look out for when you're analyzing data, though, is the quality of your data. So the first and most important thing is to be always aware of outliers. Obviously, if you have the first thing to do with an outlier is go back to the chart and check, that it wasn't just a typo that you've entered in, but if it's a true outlier, then you want to really delve deep into the case and try and work out what happened in that case. When it comes to a nomogram, if it was just a bizarre outcome, then you probably want to just exclude it from your nomogram analysis. Obviously, you can't exclude it from your outcomes analysis, but you can when you're looking at a nomogram. So you want to exclude those kind of extreme outliers for nomogram purposes. Because if you can see, especially if it's at one end or the other, then it can really make a big difference to your average regression line, particularly if you don't have that many eyes. If you take that away, then the rest of the data is on target. So you can see how much of an effect outliers can make. The other thing to look out for is, obviously, you should only really be trusting your data within the range that you have data for, so you don't want to extrapolate. And similarly, you've got to be careful if you're missing data in the middle, if you're interpolating. Now, we've only been talking about sphere at this point, so we've only been looking at one variable. So at the moment, what we've been able to do is move our cluster of outcomes onto the average target, okay? So what we haven't been able to do is increase the precision, because we've only looked at one variable so far. So what about precision? Well, to be more precise, you need to consider even more variables. And so that's where you can take this same process, and instead of only looking at sphere, you can look at as many variables as you want in a multivariate linear regression analysis. So it's using the same maths, but with more variables. And so if you do that, then you can eliminate all of the variables that are not statistically significant, and you end up with a new nomogram equation which takes into account more variables than just sphere. And this is going to improve your precision as well as your average accuracy. And so just to finish off, obviously I've been showing you sort of a way that you can do it yourself manually at home with sort of Excel or whatever program, but there are lots of programs now out there that do this for you automatically. And so these are very good options to invest in to help you to take the next step in improving your outcomes for refractive surgery. Thank you very much.
Thank you very much, Jason. If I could ask the speakers from this session just to come up to the desk here. We've got a few minutes for some questions.
Yeah, come on.
Good to see you. Good to see you, yeah.
So any questions from the audience?
I'm done. Thanks for making it.
Stunned silence. Well, either they...
Everything was completely clear, or they didn't understand a word.
Or they want lunch.
Yeah, maybe they want lunch. Dan, I'm just going to... Oh, we've got
one question.
Oh, here we are, okay.
Surely patient-reported outcomes must be a crucial factor
Well, yeah, but I mean...
in terms of auditing and...
Yeah, but the beautiful thing about refractive surgery is that, if you have the 9 grafts, if you've got no loss of best spectacle corrected vision and you have an accurate treatment, I mean, it's very parametric, refractive surgery. It's not like glaucoma, where someone can have a huge field problem and they're very satisfied. It's quite different. Refractive surgery, in fact, you can have patients who are seeing extremely well and are not happy. So that's when the patient-reported outcomes are important. But you have to be careful about that. For example, the FDA ran a study called the Prowl study, which was extremely badly designed. And this is extraordinary because it's a government body with millions of dollars of funding. Not anymore. But they ran this study and they basically looked at patient-reported outcomes at 3 months. And then they said, oh, patients had dry eye and night vision halos. All of them. It's like, well, I know. Because 3 months isn't the end point for corneal refractive surgery. So you can have ignorance applied to PROMs. But you're right, it's very important. Although I think that the reason why out of the hundreds of thousands of papers published in refractive surgery in the peer-reviewed literature, only a fraction of them have PROMs is because the parameterization kind of indicates what's going on for the most part. Yeah. By the way, another interesting thing about PROM is that you look at, it's very interesting, if you look at, and I'm going to be a little bit sharp on the edge here, but if you look at the patient-reported outcomes of multifocal IOL studies, and the modern multifocals, not the ones from 20 years ago, the patient satisfaction runs at 95%. Okay? Now you look at the 2020 rates of the studies that report it, because many studies don't use the standard graphs. They just report the mean vision or the mean outcome, mean refraction, which doesn't tell you anything about how the population did. But if you look at that, on average, the 2020 rate is about 75%. So you have 95% satisfaction with 75% seeing 2020. Whereas, if you look at corneal presbyopic treatments, which I think you're speaking about later, Presbyon, for example, on average of the 19 publications in the literature now, the average is that 93% are seeing 20/20. Guess what the PROM is, the patient-reported satisfaction is? It's 95%. Yeah, it's the same. So patient-reported outcomes need to be interpreted in the context, because you can influence a patient by telling him you're going to still need +1s to read the menu in the dim lighting, because the lens is only going to give you 30% of the light at near. So in a dim restaurant, it's not going to work. You tell them that, they're satisfied. So do you understand? Yeah, it's a double-edged sword, PROMs.
Question there.
May I ask the panel, there are so many different types of refractive laser now, PRK, LASIK, and SMILE. So most of the patients will need cataract surgery in the future. So would that make biometric measurements more difficult in the future? And second question is, when the patients opt to have like EDOF lens or multifocal lenses after this kind of laser, is there any other consideration we have to make?
Okay, well, I'll answer the first one and then I'll pass the second one on. So the question was the effect of any form of corneal laser surgery on biometry. I think that was the question. So yes, absolutely, you need to know. And it's not the headache I think it was even before my time. Even with contemporary formulae now, you can get very accurate biometry, so long as you know ideally what their treatment was, be it myopic or hyperopic. You don't need to know what type of corneal laser surgery they had. And yes, it's still less accurate than a virgin eye, But for most of us in the audience, by the time that we get a cataract, you can assume that the calculations will be even better. So that shouldn't be a rate-limiting step. But certainly patients need to know that they need to mention it and that it is an issue.
I think you're absolutely right, Dan, because nowadays with most modern formula, the Barrett and others, and the online calculator like the S-CRIS, you have comparison of several formulas, the accuracy has gone up. It's not as close as Virgin Eyes, but it's much, much better than it was just 5 years ago.
Yeah. I mean, the way you asked the question is what catches the... so you said if the patient opts for a multifocal or an EDOF lens after refractive surgery. And I would say the only patient that can opt for a certain kind of lens is a patient who has gone to medical school, did an ophthalmology residency, refractive surgery fellowship, and understands the optics of lenses. Patients cannot choose what lens they want. You should choose what lens is better for them because you're the expert. Now, on that subject, there are papers extolling that diffractive optics can be used after corneal refractive surgery, and they can. But you don't even have to do the study to know that if you have aberrations on the cornea, and you're putting a lens with a lot of aberrations in it, you're increasing aberrations. You're decreasing light transmission, and you're decreasing contrast. So even though you get PROMs that are satisfactory, it is not an ideal optical solution. And the beautiful thing of cataract surgery after corneal refractive surgery is that you have spherical aberration in the cornea. And if you're on a modern laser, you have it with an eye tracker on the visual axis, which means that you have EDOF in the cornea, which means you can use an SA60 from 1996 and get a brilliant EDOF outcome with a monofocal IOL with low PCO rate, instead of paying like 10 times more for what they call an EDOF lens now, which is actually a lens that is not aspheric, so it induces spherical aberration, which is what the lenses in the 1990s were doing in the first place. They're just charging us more for the old lenses now, having gone through multifocal diffractive lenses that they've abandoned and gone back to spherical lenses because they have spherical aberration in it, and they charge more for it. So the industry has completely let us off the cliff like lemmings, and it's very clever of them. They made money the whole way through.
The industry to some extent is leading us, which shouldn't be, in every field, from corneal refractive to lenses as well. So it's important, and sometimes that's a difficult discussion when the patient comes and tells you, I want this lens, that you explain to them in an honest way. And it's the same with laser vision correction, because this morning we've had people talking about trans-PRK, and with great result as well, although you got 2 days of pain. And the same with LASIK, and Dan does LASIK as well. So it's very important that you have an open mind, that you explain to the patient that it's not what he reads on the internet should guide, I want this lens, I want this procedure, but it's a combination of factors. And first and foremost, the safety and what the single surgeon is more comfortable. Explain to them there are other options, but there is no option that is actually perfect. If there was a perfect lens or a perfect technique, we are not stupid, we all be doing the same. So we need to adapt what we do to the patient and make them understand that we are the decision maker, not the company. That's why nowadays nomenclature of this is changing, also in laser vision correction. And I always tell my patient, got 3 procedures: surface surgery, femtolasic, and CLEX. Although undoubtedly, SMILE was the first form of CLEX and is possibly still the most advanced.
I was just going to comment, really simplistically, if you haven't already...
Can you have the microphone, please, because it's being recorded, yeah?
So I've got a microphone.
Oh, sorry. I can't hear you properly.
There wasn't enough chairs in terms of...
You are not talking now.
I was just going to say, go and look up the ESRS calculator. I'm part of the ESRS, I'm going to plug that. But it's so simple to use, and you can even put in the RK function as well, so people have had RK therapies in the past. But if you are able, like Dan said, to understand if they've had hypoplasia or if they've had like myopic treatment, and you should be able to tell from the tomography as well, which you're going to do before you're going to look, you'll be able to tell that should, with the ESRS calculator update, give you sufficient information. It's completely free, and you've got all the latest formula like Pearl as well. There's a lot of more formulas, and then you just make a good decision. So just to really simplify that point, you go on your phone today, look it up. It's there. It's really easy to use.
The only thing to be always worried is double check the numbers that you enter, because like Bruce Allen said before, transcription error is the commonest error in the surgery that we do. None of us has been exempted, and will happen to you if you do enough, so always get someone to double check that you've entered everything correctly. And having said that, I think I want to thank you and the speaker, but now we need some energy in to be ready for the afternoon, where we'll talk more about, the intraocular options of refractive surgery in general.
Lovely.